Hi everyone, we're back for part 4 and we're going to start with mumps. We know that this is a generalized viral disease that has enlargement of the salivary glands, usually the parotid. The source of infection is contact with saliva and/or respiratory tract secretions. Incubation is 12 to 25 days, and the communicability is 1 to 2 days before swelling and up to 5 days after the onset of the symptoms. Incidence of the illness has decreased by more than 99% since the vaccine has been initiated, but if contracted, there is lifelong immunity after the infection. On your clinical findings, you're going to find a prodromal phase. It is rare, but you can have fever, headaches, anorexia, neck pain, and malaise. In the swelling stage, one or both parotid glands can be swollen, and then there can be orchitis in males after puberty. The enlarged gland, the parotid gland, usually returns to normal size in about 3 to 7 days. Rarely you can see a pink rash on the trunk. If you need to see if pain is associated with that side, you can do that by having the patient eat something sour, and this is called the pickle sign, and that happens when the Stenson duct and the Wharton duct are swollen. Diagnostic studies include viral detection, serological test, or leukopenia. Your differential diagnosis include lymphadenitis, CMV, HIV, the enterovirus, a tumor, or suppurative pruritus. Care is supportive and could include corticosteroids to decrease swelling and NSAIDs. Complications could include meningoencephalitis, orchitis, epididymitis, oophouritis, myocarditis, and deafness. Let's next move on to erythema infectiosum, which is also known as the Fist disease, caused by the paravirus B19. Just in case you were curious, and this is found in the book, it got its name Fist disease because it was the 5th childhood eruptive rash described historically. It is spread vertically from mother to child. It can also be spread by respiratory tract secretions and percutaneous exposure to blood or blood products. The highest range of typically seen between 5 and 15-year-olds, but infants and adults are not immune to it. It occurs most commonly in late winter and early spring. The incubation period is 4 to 21 days. The rash lasts for 2 to 3 weeks after exposure, and it's most communicable before the appearance of the rash. Clinical findings include a prodromal phase, which may include mild fever, malaise, headaches, malaise, and upper respiratory symptoms. The rash occurs approximately 7 to 10 days after the prodromal stage, and the cheeks may appear slapped with a circumoral pallor. You may also notice a lacy macular-papular rash that may last a month, and then the rash will subside. Diagnostic studies are not indicated, and differential diagnoses include other viral exanthems. There is no antiviral treatment, but IVIG could be used in immunocompromised patients. Children may still attend school when the rash is known. Pregnant women may develop fetal hydrops with death or intrauterine growth retardation. So next, let's talk about the para-influenza virus. It's similar to the influenza virus. It's most notably known for causing laryngeotracheobronchitis, bronchitis, bronchiolitis, and pneumonia, or by fomite contamination. The incubation period is approximately 2 to 6 days. The patient is contagious 4 to 6 days before the symptoms and 7 to 21 days after resolution. Diagnostic studies include the RT-PCR testing of the nasopharyngeal secretions. Cultures can be obtained, and results are usually available within 4 to 7 days, depending on testing techniques. Your differential diagnoses include other viral upper respiratories. Management is supportive. It's mostly uncomplicated. Antibiotics are used if there's a second bacterial infection, and complications are infrequent. Next, let's talk about rubella, which are the German measles. These typically occur postnatal or in a congenital form. The disease is spread through nasopharyngeal secretions or transplacentally, but The disease is seen more in in adolescents and young adults. The virus has been isolated in blood, breast milk, conjunctival sac, and urine of infected patients. To contract rubella, you must have prolonged and repeated contact. The incubation period is 14 to 21 days. The maximum period of viral shedding and then presumed transmissibility, is felt to be about 5 days before to 6 days after the appearance of the rash. After contracting the disease, there's lifelong immunity. However, asymptomatic reinfections can occur because it can present without a rash. The actual number of reinfections is unknown. If maternal rubella infection is noted in the first trimester, there's a 61% risk of congenital deformities that could include ophthalmology, cardiac, auditory, or neurological. With rubella, about 25% of the cases are subclinical. There can be a prodromal phase where you may have mild fever, stomach issues, sore throat, eye pain, arthralgia, malaise, and headaches. There can be the lymphadenopathy that is primarily in the neck, the postauricular, posterior, and the posterior occipital lymph nodes, and you can have splenomegalia. The rash is a small rose-colored spots on the soft palate, and they can occur, and then the rash will go into complete remission by day 3. Diagnostic studies include the PCR, IgG, IgM antibodies, and is typically the clinical signs dictate the diagnostic studies. Your differential includes other viral and bacterial rashes. Management is supportive, the use of antipyretics, and it's important to keep home from daycare or school for approximately 1 week after the rash develops. Next, we're going to talk about some mosquito-borne viruses, and the first we'll talk about is the West Nile virus, which began to spread globally in 1999. It's mosquito-borne and it's rare to be transferred from human to human. Symptoms typically occur 2 to 14 days after a bite. It affects children typically greater than 10 years old. Mortality is higher in immunocompromised patients and older adults. Clinical findings may mimic the flu, and you may appear to have a GI infection. Mild symptoms will resolve typically in 1 week. If there are severe symptoms, you may see more CNS involvement, such as severe headaches, change in mental status, disorientation, awkward gait, stiff neck, tremors, seizures, respiratory failure, coma. Diagnostic studies include IgM antibodies that are linked to an immunosorbent assay. Differential diagnoses include mild viral or the flu, GI viral infections, aseptic meningitis, polio, Guillain-Barré syndrome, dengue fever, chikungunya, and the St. Louis encephalitis. Management and complications, you are focusing on supportive treatment for mild cases. If there are other associated symptoms such as meningitis, encephalitis, severe muscle weakness or paralysis, difficulty with swallowing, then the patient will be hospitalized. Antivirals are not indicated. It's important to have good patient and family education. Discuss the use of insect repellent with DEET using oil of lemon, eucalyptus, or soybean oil. It's important not to use DEET on the skin or clothing of infants less than 2 months. If this virus is suspected, it's imperative that certain questions are asked about travel and any residents outside of the U.S. Asking about the onset of fever, vaccination records, and any prior infections is important. It's important to know more about the 24-hour fluid intake, dizziness, output, and any diarrhea. You will see a febrile phase, and that has a rapid rise in the 2 to 7 day period, where you may see 2 or more of headaches, retroorbital pain, photophobia, body aches, malasias, arthralgias, facial flushing, a macular papular rash, reddened pharynx, leukopenia, anorexia, diarrhea, etc. There's a critical phase where there's a plasma leak, and you can have dengue hemorrhagic fever. You can have spontaneous bleeding. Your platelet count may be low. There may be anemia and progression to shock syndrome. Correct diagnosis and rapid treatment is very critical in this condition. In the U.S., the disease is reportable to the CDC. Management is mostly supportive and consists of fluid replenishment to prevent dehydration. In the recovery phase, you're going to see reabsorption of the extravascular fluid over about 48 to 72 hours. Dehydration and the fever in children can result in neurological issues and febrile seizures. Diagnostic studies could include a CBC, platelets, and hematocrit, checking a BUN. You may see that that's greater than 4, indicating dehydration, and total protein indicating plasma leakage signify a high risk for a hemorrhagic shock. You may also see viral serology and molecular tests performed. Your differential diagnosis could include other hemorrhagic diseases, sepsis, meningitis, management. As we talked about, correct diagnosis and rapid treatment, hospitalize or follow daily during the febrile phase. Complications are going to be based on the dehydration, and fever can cause the neurological issues. And then patient education is similar to the West Nile virus. Let's talk a bit about the hantavirus pulmonary syndrome. It's rare in the U.S. and it's caused by the exposure to rodents. You may see an abrupt fever, chills, malaise of the shoulders, lower back, and legs. There may be nausea and vomiting, a headache followed by pulmonary edema. The cardiac system may become decompensated, and blood pressure may fall. Providers should suspect this infection for a child that has an ill-defined febrile illness that may present with abdominal or back pain, who lives in the appropriate rural or an endemic geographical area for this, who also has thrombocytopenia and proteinuria and has been exposed to rodents or engaged in activities where rodents nest or waste products may have been disturbed, such as cleaning out barns or sheds. This patient may be hospitalized for management of pulmonary edema, hypoxemia, hypotension. It's important to differentiate that this is not a rickettsial disease. And then prevention is the avoidance of rodent waste. Alright, I'm going to let you read in the book more about additional noteworthy viruses in circulation, potential viruses on the horizon, and monitoring for global spread of viruses. All of that can be found in the book. We've now moved forward to slide number 96, and we're going to talk about malaria. So this is a condition that is seen worldwide and spread by the mosquito. You can have a febrile event, nonspecific illness from anywhere from 7 to 30 days after exposure. There may be high fever, chills, rigors, sweats, headaches. It may progress in severity and develop neurological issues, and even can lead to death. Diagnostic studies would include a CBC and chemistries, which may show anemia, thrombocytopenia, elevated bili, and liver function compromise. You may also be able to identify the parasite microscopically. So the treatment is based on the species identified, and then also to check for any possible drug resistance. There is a 24-hour CDC malaria hotline that you can contact for assistance with diagnosis and management. In malaria epidemic areas, treatment and prevention are very important and involve 4 measures, and that includes case management, um, insecticide-treated nets, intermittent preventive treatments of malaria in pregnant women and infants, and indoor residual spraying. The CDC offers important information regarding a traveler's risk if they are going to areas that may be prone to malaria, and further talks about anti-malarial drug prophylaxis that can vary for children and adults. Okay, next we're going to talk about some tick-borne diseases. First is Lyme disease, and it's growing in the U.S. Its prevalence is seen in the Northeast, Mid-Atlantic, Wisconsin, Minnesota, and North Carolina. It's estimated that greater than 300,000 people are diagnosed in the U.S. annually. We know that Lyme disease can present with a variety of symptoms, and only about 25 to 30% of the people diagnosed recall of having a tick bite. So your clinical findings will be divided into different stages. Stage 1 is the early localized stage, and that's generally within 1 to 2 weeks after a bite. You can have a typical rash at the inoculation site, and this is called erythema, migraines, or a bullseye. It may resemble some eczema, and you may have flu-like symptoms. So this organism moves through the hematologic and the lymphatic channels, and you can develop annular lesions. Symptoms in kids may take on a neurological component. You may see frequent headaches, lethargy, neck pain, mood swings, irritability, motor or sensor impairment. There can be cardiac issues, stomach issues, urinary type symptoms. This stage can last from a week to 2 years if there is not treatment. And stage 3 is late disease, and it usually begins with an auricular, para-auricular arthritis that develops weeks to months after the bite. The knees are most commonly affected. Joints can be red hot and swollen, but they're not as painful as other types of bacterial arthritis. If left untreated, the arthritis initially resolves in a few weeks but can reoccur. Adolescents experience the arthritis more severely and for longer periods of time. Diagnostic studies include epidemiological history. You want to look for the presence of the bullseye rash is diagnostic with no serological testing needed. IgM antibodies may not be positive for 2 to 4 weeks, and IgG until 4 to 6 weeks. There is also a high rate of false positive in the serological testing. The CDC recommends a 2-step approach by doing an ELISA from a blood sample. If negative, no further test, and then the IgG and the IgM Western blot if symptoms are greater than 30 days. Differential diagnosis includes other rashes. You also need to rule out osteomyelitis, West Nile virus, mycoplasma septic arthritis, and other sporocyte diseases. Management is prophylactic doxycycline, amoxicillin, and amoxicillin and doxycycline in the early localized disease. In the later disease, consult with ID. You can have post-Lyme syndrome, which are subjective symptoms after treatment. They may be in a chronic form or may be persistent related to immune-mediated inflammation. It's important to educate the patient and the family about avoiding tick-infested areas and take precautions when outdoors, and important to teach how to remove ticks safely. I'm going to let you finish out this section in the book, which is talking more about other tick-borne illnesses, and we'll close out this video, and then we'll start back up with bacterial infections and hopefully be done with everything. Thank you for your patience.